and welcome to Fits on the Go. My name is Melissa Lyle, and I'm a cardiology fellow at Mayo Clinic in Rochester, Minnesota. I'm here at ACC 19, and I'm joined by Dr. Manesh Patel, Professor of Medicine and Chief of Cardiology at Duke University. He'll be presenting on the impact of FFRCT on one-year outcomes of patients enrolled in the Advanced Registry. Thank you so much for being here today with us, Dr. Patel.
Oh, thanks for having me. It's really
Great. So can you remind us a little bit about the Advanced Registry and also the design of the initial prospective trial?
Yeah, I think importantly for fellows, I would say, at this time in your career, you're thinking about what's going to be important in clinical care. And I would say coronary physiology is having a rebirth, if you will, right? There's been interest in invasive FFR, IFR, and then here we're presenting the Advanced CT-FFR Registry. So just to remind people what that is, it's a 5,000 patient prospective observational registry where we were looking at what impact does FFRCT have on top of just the CTA, so the FFR portion from heart flow. How does that change your decision making? And just to remind everyone, those 5,000 patients were enrolled internationally at 70 sites or so. And those patients were patients that were suspected to have coronary disease, had at least 30% atherosclerosis or more, all the way up to 90. And then the site said, this is what I would do based on the CT. And then they got the FFRCT result and they said, oh, now this is what I would do. We also had a core lab. So the first goal was just to say, how's it used in practice and does it change clinical practice, or at least the way people are going to treat patients?
Okay.
And these results, the initial results were presented at ESC 2018, published in the European Heart Journal, and they showed that about 60% of time, the FFRCT finding, that pressure finding of greater than or less than 0.8, changed how people were thinking about the CT. Often, there's a when it's negative and there's no disease, pretty clear. If there's stenosis, it's unclear how much. Is that significant? Is it functionally significant? Much like the cath lab, where we'll have a stenosis where we'll be wondering. So it changed that. But even if it changes your practice or changes how you think about a patient, you might say, well, what outcome does that have? Is that important to how my patient's treated? So here, we were lucky enough with the investigators and all of the patients that participated to follow the majority of these people out to 1 year and to look for MACE, death, MI, ACS leading to hospitalization with revascularization, a core lab featured sort of endpoint. The first finding was that the findings of MACE were low. In fact, might speak to less than 2% of all patients had these events. So it tells me that we might be testing patients that are a little too low risk. That's an important first message, right? The second was that if your FFRCT was negative, normal, or above 0.80, very few of those patients got revascularization. Most of them were conservatively managed, less than 10%, less than 5%. And very few of those patients had MACE. Now, compared to those that were above less than 0.80 or abnormal FFRCT. So CV death and MI occurred about half the time compared to those that had an FFRCT above, but it was still a low number, and MACE trended towards being better. So what are my conclusions? Most people might say, well, Manesh, what does that mean? I guess it would give me reassurance that if I was in clinical practice using FFRCT like it was in this study, meaning that patients who had a normal one generally didn't go to the cath lab, got medical therapy and were followed, the event rate was low, and they seem to be reassured that they could be probably medically managed. Like you do with a FFR that's maybe not abnormal.
Okay, great. And given all of your experience and your research, what advice do you have for practicing cardiologists and fellows about when to start using the FFRCT and how to apply that into our practice?
I think, that's a great question. I think we still need more research. By no means do I think the existing modalities don't work well. In fact, they do. Right? We've had CT versus stress testing studies, randomized studies. I think the first message for me is, for fellows and faculty, you need to start getting comfortable with these other technologies. You need to know how to look at a CTA. If you're an interventional fellow this day and age, knowing physiology both in the CT and in the invasive arena is going to be important. And then I think in clinical practice there's some ongoing studies, and I suspect what we're going to see is more data on who we should and should not test. There's a randomized trial called PRECISE ongoing about that. And then some trials that are planned, one called Decision with Dr. Stone and others, where there might be a CT with FFR prior to going to the cath lab.
Oh, interesting.
So I think there are going to be two pathways.
Okay.
And I think those are going to need to be studied to see if they're truly beneficial for patients, but I think they're going to be important.
Okay, great. Any final thoughts or insights from the analysis?
I think the biggest analysis insight, and there were limitations because it's an observational registry, is that it's starting to get uptake and people are getting better at using CT and FFRCT. Okay. And that's going to correlate to another study presented here, Define PCI, where invasive IFR pre and post intervention is going to tell us about what's the residual pressure drop or ischemia.
Okay.
So I suspect as we think about patients' anatomy and ischemic functional data, we're going to do a lot more pre-procedural planning than we do today, where we just go to the cath lab. We're going to either know the anatomy better, we're going to know the pressure drop better. In the cath lab, we're going to be better about where we test, where we put the stent. Okay. That's the hope.
Perfect. Great. Well, thank you so much for joining us today. We really appreciate it. And thanks for all the great insight.
Thanks for having me.
Great. And for more videos like this, please go to youtube.com/FITsOntheGO.